The following podcast is part of a certified educational activity titled Uncovering the Role of Epithelial Cytokines in CRSwNP, Examining the Clinical Implications of New Approaches with Targeted Biologic Therapy. Access the entire activity and complete the post-test at peerview.com/AYT860. Downloadable slides and practice aids are also available.
Good evening. Thank you for joining us. Today we're going to be discussing uncovering the role of epithelial cytokines in CRS with NP. So for our goals for tonight, we'd like to expand your knowledge of the role of epithelial cytokines in the pathogenesis of CRS with NP and the rationale for use of biologic agents, improve your ability to examine recent clinical evidence on the efficacy and safety of biologic agents targeted at epithelial cytokines, and provide you with guidance on the selection of patients with CRS with NP who may be candidates for treatment with biologic agents targeted at epithelial cytokines if approved. So I'm going to start by reviewing the role of epithelial cytokines in the pathogenesis of CRS with nasal polyps and the rationale for targeted treatment. So we're going to start off by reviewing a patient case. This is Jim, a 50-year-old electrician who has chronic rhinosinusitis with nasal polyps, also allergic rhinitis and asthma. His symptoms started around age 45 when he developed progressive nasal congestion and then anosmia. He was found to have chronic rhinosinusitis with nasal polyps, underwent his first endoscopic sinus surgery at age 46, but tells me that his polyps came back just a few months later. He actually was treated around that time or thereafter with subcutaneous allergy immunotherapy for dust mites, cat dander, tree pollen, weed pollen, and mold, but didn't get much better. At age 49, required a second endoscopic sinus surgery, actually had a steroid-eluting stent placed at that time, and was maintained on intranasal budesonide irrigations thereafter. Felt pretty good after surgery, but unfortunately this time, about 5 or 6 months later, he had progressive nasal congestion, anosmia, which was really responsive only to oral prednisone. On nasal endoscopy, he had grade 3 polyps bilaterally. His SNOT-22 score showed significant impairment in his quality of life. The score was 47. He underwent an oral graded challenge to aspirin, which was negative. He did not react. And at this point, he was on budesonide irrigations twice daily, fluticasone inhaler, montelukast, cetirizine, and albuterol as needed. In terms of his labs, his blood eosinophil count was 600 and his total serum IgE is 239. And here is a look at his CT scan. We see that this is a patient who's had surgery before, and he has significant pan-opacification of the nasal polyps. I don't know, Joe, if you want to weigh in at all here as well.
Yeah, so what we see is a coronal CT of the sinus bony window. And what we mostly see are the maxillaries and ethmoid sinuses. We see that the middle turbinates are partially resected. And you can see that the maxillary sinus on both sides are completely opacified, as well as the ethmoid sinuses are completely opacified. It looks like the patient had prior sinus surgery, and there are some partitions still in the ethmoid sinuses, but most of the ethmoid sinus partitions have been opened up.
So, this is actually, I think, a pretty common patient for us to see who's presenting with severe nasal polyps. So in terms of how do we evaluate and diagnose chronic rhinosinusitis, so this is all comers with chronic rhinosinusitis with and without nasal polyps, we look for patients who have 2 or more of the following symptoms for 12 or more weeks, and this includes mucopurulent drainage, so either rhinorrhea or postnasal drip, nasal obstruction or blockage, so people who are coming with congestion, facial pain or pressure, and then impairment in sense of smell. And in our patients who have polyps, we see that nasal obstruction or blockage and sense of smell impairment are really significant symptoms that they complain of. This is paired with objective findings of nasal mucosal inflammation or sinonasal mucosal inflammation, including nasal polyps in patients who have chronic rhinosinusitis with nasal polyps or otherwise mucosal edema, and then inflammation of the paranasal sinuses on imaging. We know that chronic rhinosinusitis with nasal polyps leads to significant impairments in patient quality of life. So our patients who have chronic rhinosinusitis with nasal polyps report impairment in both physical and emotional domains. So they have the nasal symptoms that we talked about, And cough can also be a problem for these patients, or exacerbation of asthma or increased asthma symptoms. Patients with chronic rhinosinusitis with nasal polyps can actually have ear symptoms, so they can complain of ear congestion or pain, pressure, and even conductive hearing loss. And patients can also have emotional or sleep symptoms. So chronic rhinosinusitis with nasal polyps can be associated with anxiety and depression, difficulty with sleep, daytime fatigue, and then impairments in productivity at work and lost time at work or school. In terms of classification of chronic rhinosinusitis, about 20% of patients who have chronic rhinosinusitis with nasal polyps, meaning that when the otolaryngologist looks via nasal endoscopy, they see polyps on exam. This is associated with high levels of tissue eosinophilia, and in Western countries, it's associated with a T2 predominant inflammation or type 2 predominant inflammation. About 80% of patients with chronic rhinosinusitis have chronic rhinosinusitis without nasal polyps, which is a little bit more heterogeneous. It's associated with type 1, type 2, and type 3 inflammation, often less eosinophilic infiltration. And patients who have chronic rhinosinusitis with nasal polyps should be assessed clinically and ask the question about any past reactions to NSAIDs or aspirin, any medication that inhibits cyclooxygenase 1, which is a clue that this patient might have aspirin exacerbated respiratory disease, which is really a severe phenotype of chronic rhinosinusitis with nasal polyps, and important to consider in the evaluation of a patient with chronic rhinosinusitis with nasal polyps. In terms of the traditional treatment approaches for chronic rhinosinusitis with nasal polyps and what we've done, often first-line therapy is topical intranasal steroids, often paired with nasal saline irrigation. And in terms of the intranasal steroids, there are several different delivery methods that are employed. Nasal sprays are often reasonable to start with and easy for patients to use. The exhalation delivery system can be an effective modality to use for patients with nasal polyps. Nasal steroid drops or irrigations can be used for these patients and are often employed, and steroid-eluting sinus implants can also be used. Antibiotics can be useful in treating acute infections in patients who have chronic rhinosinusitis with nasal polyps, but the evidence of clinical significant efficacy in terms of long-term use is lacking. And leukotriene modifiers may be helpful in certain settings. They're certainly helpful for patients who have aspirin-exacerbated respiratory disease. And then systemic steroids can be quite helpful in terms of treating patients' overall symptoms, and lead to reduction in a lot of symptoms that patients complain about, including nasal blockage or congestion, and anosmia or hyposmia, the impairment in sense of smell. But it's recommended that these steroid courses be limited to short-term use only, given the known adverse effects with cumulative exposure to oral or systemic corticosteroids in a patient's lifetime. So we really only use systemic steroids for a very short amount of time. And in a patient who feels like they always are needing a systemic steroid, we really tend to move toward escalation of therapy in that setting. So in terms of next steps when medical treatment is unsuccessful, so that first-line therapy with intranasal steroids and saline irrigations, patients are often evaluated for sinus surgery at that time, for endoscopic sinus surgery. And this really has a goal of decreasing the overall inflammatory burden, debulking the polyp tissue, and then making larger openings in the sinuses so that the intranasal medications can be delivered topically into the sinus cavity. By debulking the polyp tissue and opening the sinuses, the intranasal corticosteroids can really get to the focus of inflammation up in the sinuses. And it's really important, and I think, we can have Joe speak to this, that these patients undergo good post-surgery maintenance therapy with ongoing topical steroid delivery.
When we talk to patients about sinus surgery, we say exactly what Katie said. We want to decrease the inflammation so that the medical treatments can work, and not only because the openings of the sinuses are bigger, so that the topical medications like steroids can get in there better. But it allows the medical treatment to try to control the inflammation better by decreasing the inflammatory load.
Awesome. Thank you. And, thinking a little bit more about what happens after surgery, many patients do really well, but there are patients who have recurrence of their chronic rhinosinusitis with nasal polyps after surgery. And, recurrent rates vary depending on different populations that were studied and, when studies were conducted, but it can range from as high or up to as high as 40% of patients who have surgery. In older studies, recurrence rates were about 30% after 6 months of surgery, 38% at 12 months, 40% at 18 months. With newer endoscopic approaches, the recurrence rates have decreased. And I was hoping, Joe, that you could talk a little bit more about that as well.
Yeah, thanks, Katie. It's actually kind of interesting, and we know that chronic sinusitis with nasal polyp is not really controlled by sinus surgery, but especially traditional sinus surgery. So we were trying to find more aggressive ways to try to do a more advanced and more bigger opening sinus surgery to try to decrease the incidence of nasal polyps. So what we did is what we call an endoscopic modified Lothrop procedure, and that's what it's called in the U.S. In Europe, it's called a draft 3. And what that is basically drilling down the floor of the nasal cavity, making the frontal sinus really big, because that's usually where the nasal polyps usually recur. Now, one of the other things that we've done is kind of going back to historically to what we do is if the polyps keep coming back, we strip the mucosa, what we think is a diseased mucosa from the bone, and then allow abnormal and scarred epithelium to form. And that's part of the theory behind the reboot theory, reboot sinus surgery, because what we're doing is we're stripping the mucosa off the ethmoid sinuses, and what we're trying to do is remove the diseased polyps, and what usually grows is like transitional scarred epithelium that doesn't make polyps. But in the era of biologics and some of the new treatments that we have, we kind of wonder, are these more aggressive surgery really needed? So, they have kind of fallen in favor a little bit, but I kind of wonder if they're falling out of favor now.
Wow, that's really, really interesting. And it'll be interesting to see kind of, what we learn about, different surgical techniques and the era of biologics over time. So the last bullet point I think is important, which is that type 2 inflammation is associated with more severe sinus disease and symptoms, and also associated with recurrence after surgery. So patients who have sort of the very classic type 2 inflammation driven by cytokines like IL-4, IL-5, IL-13, eosinophilia, those patients are more likely to have poor postoperative outcomes. It is certainly known that up to 65% of patients who have CRS with NP have comorbid asthma. The prevalence of asthma in the general U.S. population is about 8.5%. So these diseases tend to often go together. And CRS with NP is associated with adult onset asthma more frequently than childhood onset asthma. And we know that the CRS with NP and asthma endotype is associated with really more severe type 2 inflammation and more likelihood of recurrence following endoscopic sinus surgery compared to the CRS with NP endotype by itself. And then I mentioned earlier about aspirin-exacerbated respiratory disease, which is also known as non-steroidal anti-inflammatory drug exacerbated respiratory disease. But up to about 25% of patients with CRS with NP have comorbid aspirin or NSAID exacerbated respiratory disease, which is really important as these patients have very high likelihood of recurrence following endoscopic sinus surgery. They tend to have much higher burden of inflammation in the sinuses and be quite symptomatic. So in terms of type 2 inflammation, which is really the predominant inflammatory endotype we see in chronic rhinosinusitis with nasal polyps, it's known that in nasal polyp tissue, the epithelium is profoundly dysregulated, and we think that an external insult like allergens, pollutants, viruses, proteases can lead to alarmin production or innate type 2 cytokines from the epithelial cells. And this includes interleukin 25, 33, and thymic stromal lymphopoietin, or TSLP, which can lead to downstream adaptive cells like ILC2s or Th2 cells to produce type 2 cytokines like IL4, IL5, and IL13, which can have effects on a variety of different immune cells and also feed back onto the epithelium. So we see here in this figure, IL4 can lead to class switching B cells to Ig producing cells, which then can act on mast cells and basophils. IL5 can lead to eosinophil differentiation, activation. IL13 can certainly lead to increases in mucus production, airway remodeling. And, we see this quite commonly in chronic rhinosinusitis with nasal polyps, really specifically in patients who have comorbid asthma with CRS with NP. And, what do we have now to offer these patients? We will talk in a little bit more about the efficacy of some of the biologic treatments for chronic rhinosinusitis with nasal polyps. But in terms of where they're targeting these dysregulated immune pathways, we know that targeting IL-5 or IL-5 receptor, targeting the IL-4 receptor, which can block IL-4 and IL-13 signaling, targeting IgE, can have a variety of different effects. Certainly, it can have effects on eosinophils in terms of differentiation, activation, survival, recruitment to inflammatory tissue, and release of some of the inflammatory products of eosinophils. It can also act on basophils and mast cells. And there's evidence that certainly blocking IL-4 receptor can have impacts on the respiratory epithelium. There's some emerging evidence that blocking IL-5 can also have impacts on respiratory epithelium, and known actions on B cells or plasma cells, airway smooth muscle, and macrophages. So really, these medications can target a variety of different inflammatory cells and mediators that are central to the pathophysiology of chronic rhinosinusitis with nasal polyps. So moving on, talking about TSLP and chronic rhinosinusitis with nasal polyps. So it's known that TSLP, mRNA, and protein are both elevated in the epithelial cells, infiltrating cells of patients with nasal polyps. TSLP has a role in inducing production of type 2 cytokines, as we talked about a few slides ago. And the production of TSLP by epithelial cells can be controlled by both innate and adaptive signaling pathways. And targeting type 2 inflammation in chronic rhinosinusitis with nasal polyps, especially TSLP, can reverse actual structural changes through reprogramming of structural cells in interaction with their environment. So we talked on the last slide about how the epithelium and other structural cells can be impacted by type 2 cytokines, and targeting these can really have an impact on chronic rhinosinusitis with nasal polyp epithelial and structural cell tissue. So going into a little bit more detail about TSLP in chronic rhinosinusitis with nasal polyps, we see here from this study that TSLP mRNA levels are higher in polyp tissue compared to sinus tissue from healthy people, patients with chronic rhinosinusitis without nasal polyps. And again, this is in the scrapings from sinuses and also sinus tissue. We also see that there's more TSLP receptor in the nasal polyp tissue, and that the TSLP receptor and TSLP mRNA levels correlate positively. Looking at the protein level, we see that in whole nasal polyp tissue, if you look at the figure on the top right, there is higher levels of the cleave active form of TSLP in patients who have aspirin exacerbated respiratory disease, so really severe phenotype of chronic rhinosinusitis with nasal polyps compared to patients with chronic rhinosinusitis. And looking at the bottom, you can see the Western blot showing again that the TSLP protein is higher in patients with AERD compared to patients with chronic rhinosinusitis. So when we think about TSLP and chronic rhinosinusitis, a potential hypothesis that is TSLP is produced by the epithelium found in the airways, skin, also eye mucosa, which by targeting it, you're really targeting a universal molecular pathway, which is used to transduce a warning signal. And beyond just the concept of the unified airway, really the idea that one biologic in a patient can target the whole spectrum of T2 inflammation expressing organs is something that I think we should consider when we're targeting TSLP. And then lastly, in this figure, we see really a summary of possible biologic mechanisms which are involved during CRS. And we can see places where treatment with a monoclonal antibody targeting TSLP might be effective. So as I mentioned, we see at the top here with the epithelium that the production of TSLP in epithelial cells can be triggered by external insults such as viruses, fungi, proteases, and here they show you particulate matter potentially causing this. And TSLP can really promote downstream type 2 inflammation by signaling through its receptor, the TSLP receptor, which can be expressed by a lot of different cells, including dendritic cells, ILC2s, mast cells, eosinophils, et cetera. And this can lead to release of IL-4, IL-13, which can signal through IL-4 receptor. And that can, as I talked about earlier, act on a variety of different cell types. We also see here that this can lead to release of inflammatory eicosanoids like prostaglandin D2 from mast cells, and that can cause further recruitment of inflammatory cells by signaling through CRTH2 or the DP2 receptor. And then we see, IL-5, which is all part of this pathway, can also act on eosinophils via the IL-5 receptor, leading to the recruitment and activation as well. On the right side, there's a figure really depicting the hypothetical mechanisms of polyp growth, which is focused on reprogramming. We know that the basal epithelial cells in the polyp environment are really profoundly dysregulated. They tend to be locked in this kind of uncommitted state. And in nasal polyps, TSLP expression is really uniquely restricted to basal cells and airway epithelium. And then lastly, highlights roles of the ALOX15 or 15-lipoxygenase pathway, and then cystatins and the P-glycoprotein axis as well. So, I think in summary, this is really a complicated system, and it is really just even scratching the surface here. I think that it's so much more complex than we even know. But again, I think it highlights why targeting epithelial cytokines can be attractive, given its impact on multiple downstream pathways. So let's take a look at a brief 3D animated clip on the role of epithelial cytokines in chronic rhinosinusitis with nasal polyps.
Healthy nasal epithelium maintains homeostasis through a variety of immune and non-immune functions, including acting as a physical barrier to environmental agents. When pathogens and other irritants are inhaled, the nasal epithelium may be compromised, initiating a cascade of inflammatory events. Epithelial cytokines such as thymic stromal lymphopoietin or TSLP, IL-33, and IL-25 are released. These cytokines act as alarm signals, initiating and perpetuating the inflammatory response that leads to chronic rhinosinusitis with nasal polyps, or CRSwNP. TSLP is a key player in this process. By binding to receptors on dendritic cells and other immune cells, TSLP drives the differentiation of naive T cells into Th2 cells, which produce additional inflammatory cytokines such as IL-4, IL-5, and IL-13. This Th2 skewed response is central to the chronic inflammation observed in CRS with NP. Recent evidence also indicates that damage to the epithelium may initiate epithelial mesenchymal transition, or EMT, where epithelial cells transform into fibroblasts that promote tissue remodeling and ultimately polyp formation. Epithelial barrier dysfunction and impaired mucociliary clearance can lead to accumulation of pathogens and allergens, amplifying the inflammatory immune responses. Inflammation and remodeling at the epithelium promote one another in a positive feedback loop. Restoring epithelial homeostasis may lead to disease remission in CRS with NP, and biologic agents targeting the epithelium may be key in treatment. Tezepelumab, a monoclonal antibody that blocks TSLP, is in phase 3 trials after earlier studies showed it reduced nasal polyp size and improved symptoms such as congestion and sense of smell.
And now I will turn the next part of the presentation over to Dr. Hahn.
Hey, Katie, thank you very much. That was a great talk and really a nice summary of everything that has been going on how nasal polyps are formed and what's causing it. So I think that's very exciting. My name is Joseph Hahn. I'm a professor at Eastern Virginia Medical School and the vice chair for the Department of Otolaryngology Head and Neck Surgery in Norfolk, Virginia. I'm going to be talking to you about looking at the evidence and of different biologics that have been approved or in the process of being approved for the treatment of chronic sinusitis with nasal polyp. And then, who are the patients that would benefit most from the use of biologics? Here are the 3 biologics that have been currently approved by our regulatory agency for specifically for nasal polyp. We have dupilumab that is an IL-4 receptor antagonist, so therefore it blocks IL-4 and IL-13. Dupilumab is also approved for other cold diagnoses such as atopic dermatitis, eosinophilic or steroid-dependent asthma, eosinophilic esophagitis, prurigo nodularis, and most recently eosinophilic COPD. And dupilumab also recently got approved for pediatric chronic sinusitis with nasal polyp down to the age of 12. The omalizumab, which has probably been the longest biologic that we've had, targets circulating IgE. That's been approved for allergic asthma, chronic spontaneous urticaria, and most recently this year for food allergy. Mepolizumab, which targets circulating IL-5, has been approved for, also been approved for eosinophilic asthma, eosinophilic granulomatous with polyangiitis or EGPA, as well as hypoeosinophilic syndrome or HES. Now, these are the some of the data from the phase 3 study for dupilumab. And what we see here, and the part that I really want you to look at is nasal congestion. And we see that when the patient with severe nasal polyp is given dupilumab, we see there's a sharp decline in the symptoms of nasal congestion. And you can see that it steeps pretty quickly, about 3 to 4 months. And then even after 4 to 6 months, it continues to decline. But once you stop it, what you see is that the symptom of nasal congestion, which is very sensitive, still has a sustained effect for 2 months. And so, and that's kind of interesting. So that means that if you give a patient dupilumab for 6 months, every 2 weeks for 6 months, and you stop it, you can see that the patient's symptoms are sustained for about a couple of months. And what we see here is the use of antibiotic and steroids. And we could see that in patients who received dupilumab, the use of having systemic steroids or undergoing sinus surgery has decreased almost by 3 times as much. And so if you got dupilumab, you were almost 3 times less likely to either use systemic steroids or sinus surgery, which is what patients want. Now, this is from the phase 3 study for omalizumab. Now, omalizumab was very interesting. So they had a placebo, is a randomized controlled study where one got placebo, the other one got omalizumab, and they did that for 6 months. The second 6 months was an open label study in which patients, both in the placebo group and the treatment group, got omalizumab. And what you see here is that the patients who were initially given omalizumab, who were continuing on omalizumab, continue to get better. And you see in the patient who got the placebo, meaning background nasal steroid spray, when they got omalizumab during the open label study, you see a sharp decrease in their nasal polyp score as well as the congestion. But what happens when we stop the omalizumab? and that is during the follow-up last 6 periods. So from month 12 to month 18. And what you see here is that in omalizumab, you don't see that the symptom, especially nasal congestion, which tends to be a little bit more sensitive, you don't see that sustained effect with omalizumab like we did with dupilumab. And so here, if you stop the omalizumab, the symptoms of nasal congestion seems to come back within the first month. Now, this is the study from the mepolizumab SYNAPSE study. This is the phase 3 study for mepolizumab. And this is just looking at the nasal polyp score. And what we're seeing here is that you can see that the nasal polyp score, when it's given over a period of a year, you can see that the polyp score continues to get better and better and better. But once you stop it after a year, so week 52, you would, based on the dupilumab data and the omalizumab data, that you would think that the nasal polyp score should come back really high. And what you see here is that for mepolizumab, it seems to have a little bit longer durability, meaning that if you stop the mepolizumab, is after a year of getting mepolizumab, it looks like the effect of the mepolizumab or the benefit of the mepolizumab on the nasal polyp score and the nasal congestion seems to last a lot longer. It may, based on the phase 3 data, it seems to maybe even last as far as 6 months. So that's kind of interesting because one of the things that we're interested in is if we give a patient a biologic, do we have to continue them on the biologic? And that's a very common question that we get. And so, when we tell patients, if you have bad nasal polyp, you don't do well with surgery or medical treatment, and we need to do something more. Biologic is what we need to do. And then the first question we usually get is like, how long? And initially, we didn't really know. But as the data has come out, we started to understand that maybe there's a process for a step-down therapy, and maybe there's even a process where we can maybe eventually get them off that. And so what do I mean by that? And so this is a really nice study done in Amsterdam by Whiskey Folkens and those group. And so what they did in the Netherlands is if we give a patient dupilumab, and what they did is specifically look at dupilumab, if we gave them dupilumab for 6 months or a year, can we start increasing the interval between the dosing and still maintain some control, some level of control, meaning the polyp scores are stable or have improved or disappeared, and their symptoms are well controlled, meaning they have very little symptoms. And we shouldn't be completely surprised by this, because in the dupilumab sinus 52 study, the second half of the Science 52 were 2 treatment groups, one which got dupilumab for 2 weeks, the other one that got it for 4 weeks. And when we look at the data between that second half, those who got 2 weeks versus 4 weeks really didn't show a big difference. And that's kind of what we're seeing here in real life. So what we see is patients who are getting dupilumab, they're getting it every 2 weeks for 6 months. And then some of these patients are starting to spread out the interval between dosing. So instead of doing it every 2 weeks, they're getting it every 4 weeks. Some of them are getting it every 6 or 8 weeks. And even with that, their response has still been very good. And so that's very exciting. So then here, what we're starting to see is that, maybe patients who are getting these biologics, after we're able to suppress the high inflammation that was uncontrolled in the beginning, maybe we don't need as much to maintain that level of a low inflammation. I think there's still more to be seen, but I think this is a very exciting data. And so here, what we see is, again, other objective measures of, smell and SNOT-22, which is a patient-reported outcome measure, as well as a nasal polyp score. So here are patients who are given dupilumab for every 2 weeks for the first 6 months. And then when we start spreading out the interval between that, they're able to still maintain the level of, of smell or sense of flavor, and the patient severity of their sinusitis symptoms seems to be well controlled. Their SNOT-22 is level, as well as the nasal polyp score. It seems to go down and still sustain despite having longer interval between the doses of the interval. And this is specifically just for dupilumab. We haven't seen any other data for other biologics for nasal polyp yet. So here is another study looking at specifically ARD patients. These are aspirin triad patients. And we see here that patients who are getting the interval of dupilumab, we could see that this is another study showing that patients with the most severe nasal polyps, when we increase the interval between 2 weeks, 3 weeks, 4 weeks, and maybe even up to 8 weeks, that they're still able to do well by increasing the interval. So I think, we're going to start seeing more of these similar data for maybe hopefully other biologics as well. But so far what we're seeing mostly is for dupilumab and increasing the interval between the dosing. Now, with these biologics that have been out for a while, we're starting to also gather some other information. And so specifically, if we look at the phase 3 data for the 3 approved biologics for nasal polyp, we see in the data that the adverse effects is very low and that there really isn't any issue. But as we've been using the biologics a little bit longer, we're giving them longer than a year, we're starting to see some interesting information. And so this is a study done by a group of otolaryngologists from Vancouver, Canada. And what they did was they looked at patients who had either mepolizumab or dupilumab, and they didn't have any patients for omalizumab for nasal polyp. And what they did was just look at some of the adverse effects. And you can see here that there were a group of patients who stopped using the biologic because the symptoms were, or the adverse effect was high enough where they stopped it. And what you see is there's a trend for arthralgia. So it may be inflammatory arthritis that are getting expressed, and rash. Now, I did talk to the authors to see, what exactly was arthralgia and rash, and it was limited by what was written in the charts. But I suspect that, the arthralgia probably may be a manifestation of inflammatory arthritis, and the rash, I suspect, may be psoriasis. But again, not very clear, and there are more people looking at these data. And so as the biologics have been around for a lot longer for nasal polyp, we can start looking at these adverse effects. So what we're seeing is that, yes, in the phase 3 study, I think they're very safe. Biologics that target asthma and nasal polyps are very safe, but what we're seeing is maybe there are some adverse effects that are out there that wasn't very clear during the phase 3 studies. And so now there are other biologics that are currently getting evaluated for nasal polyp. One of them is tezepelumab. It's called the Waypoint study. But in order for tezepelumab to get approved for asthma, the phase 3 study was the Navigator study. And so in the Navigator study, we had a certain number of patients who had chronic sinusitis with nasal polyp. So these are patients who had symptoms and diagnosis of nasal polyp. And so what we did was we did a subgroup analysis. And what we did was, we looked at these patients and we said, if they have asthma and nasal polyps, how did they do? And we could see that patients with those who have polyps did better. And so when we look at the percentage of annual acute exacerbation over a period of a year, that patients with nasal polyp did a little bit better than those without nasal polyp. And I think that's not surprising because these patients with asthma and nasal polyp tend to be the more severe, and it seems to show that tezepelumab seems to have a a very good response in patients with both the co-diagnosis of asthma and nasal polyp. And I do think that that's something that we have seen both clinically in real life. And here we're looking at patients who were diagnosed with nasal polyp. So these are patients with asthma, self-diagnosed with nasal polyp. And when we look at SNOT-22, we see that those who had nasal polyp also had a better improvement in the SNOT-22. So SNOT-22, as I said earlier, is a patient-reported outcome measure or quality of life measure for sinusitis. So we can see that from this subgroup analysis from the Navigator study that patients who have asthma and also self-diagnosed with nasal polyp, they also seem to have a response. So I think that's very exciting. And what that means is that, that the Waypoint study, which is tezepelumab being used in patients with CRS with nasal polyp, will likely have a very positive results. We don't have that data yet. Hopefully we'll have that data soon. And these are other ways of looking at the certain domains within the SNOT-22, and it seems to show that tezepelumab seems to improve all the different 5 domains of the SNOT-22. Now, there are different ways you can break up the domains with the SNOT-22, but I think the one that's the most relevant and seems to be the most predictive of whether or not it's going to work or not is the nasal domain. So on chart A. And you can see there that there is a statistical improvement within all domains, and most importantly, within the nasal subdomain of SNOT-22. So again, these are evidence to show that tezepelumab will also work in chronic sinusitis with nasal polyp. And so here is a nice forest plot of those who had polyps and who didn't. And what you see here is that that the patients, with nasal polyp and asthma, did well with tezepelumab, and you can see that any of the plots that are more on the left side favors tezepelumab, while those on the right side favor placebo group. And so for the most part, it seems to show that patients with high ability eosinophils, people with presence of FeNO, IgE, IL-5, IL-13, all tend to do very well. So again, everything that we've seen so far from the subgroup analysis from Navigator study seems to show that tezepelumab will likely improve our patients with nasal polyps. Now, another biologics that has undergone 2 phase 3 studies is benralizumab. So benralizumab had 2 phase 3 studies. One is called Orchid, and the other one is called Austro. So the Austro was done first, and during the phase 3 study for Austro, it was unfortunately interrupted by COVID. But from one of the phase 3 study, which is Austro, we could see that patients who got benralizumab for the nasal polyp seems to show that the patients do have improvement in the nasal polyp score, and they also have improvement in the patient's symptoms of nasal congestion. And those were the 2 primary endpoints being evaluated in Austro. So it seems to show that benralizumab has potential to also improve our patients with chronic sinusitis with nasal polyps. And so we'll have to kind of wait to see what we see in Orchid. And so the Orchid was the second phase 3 study evaluating benralizumab in patients with CRS with nasal polyp. We don't have that data yet, and hopefully we'll get that data. Now, there are other biologics that are also in phase 3 and have recently been completed. The other biologic that has completed a phase 3 study is depemokimab. And so depemokimab it targets circulating IL-5, and the 2 phase 3 studies was Anchor 1 and Anchor 2. And so we don't have data on that yet, but that should be hopefully coming out soon. So, now that we've talked about some of the efficacy and safety of the biologics with nasal polyp and showed that it does work, the next question comes up is, how do we decide who should get the biologic? And so there's a group of rhinologists and physicians, and the EPOS and the Euphoria physicians are made up of otolaryngologists, allergists, pulmonologists, and we have all gotten together as a group to say, since there are so many biologics are out there, how do we decide who should get it? And so one of the ways we've kind of initially described it was looking at patients with nasal polyp. So they have to have nasal polyp. We say that they should have a type 2 inflammation. And the way we defined it as having high tissue eosinophils greater than 10 eosinophils in a high power field, having a blood eosinophils greater than 150, or having a total IG greater than 100. Now we know those are low bars, but those are one ways that you can clinically determine if a patient with nasal polyp is a type 2 disease. Other ways we've kind of defined is, that these are patients who are severe or uncontrolled. So these are patients who are requiring at least 2 or more systemic steroids in a year. And so these are patients who are getting over 400 or 500 milligrams of prednisone in a year. So that's a lot. These are patients who are more severe and probably not well controlled. And so another way to define whether or not someone has severe sinusitis is having a SNOT score greater than 40. And we know that patients with nasal polyp, one of the best symptoms of deciding whether or not polyps are starting to come back is whether or not they lose their sense of smell. And now, smell can kind of be a little bit misleading for patients. So what I use is the word flavor. So if you're eating a pizza and the pizza doesn't taste good, that means you probably lost your sense of smell or flavor. Sometimes they get smell mixed in with taste, but I think smell and flavor is a pretty good word. Now, if you also look at patients with nasal polyp, the people who usually tend to have the more severe nasal polyp are usually patients with co-diagnosis or comorbid asthma at the same time. Another way to look at it is that there is this multidisciplinary management strategy looking at patients with nasal polyps. So now this paper was also written by a group of otolaryngologists and allergists, and got together and said, if we have a patient with nasal polyp, what should we do? And this is more focused around the U.S. And so and we were looking at regulatory approved products or treatments that were common practice. And so what we all agreed on, what all the experts agreed on, is that they should have both subjective and objective evidence of nasal polyps. We should maximize topical therapy or maybe give them a short burst of steroids. So, those are all things that I think everybody agrees on. These are things that are over the counter, like nasal steroid sprays are over the counter. And one of the questions that came up is, if we do a nasal steroid spray, how long do we say that it works or it doesn't work? And we agreed, the experts agreed, that it should be about 4 weeks. And after we've kind of maximized the topical therapy and give them a little bit of systemic steroids, what do we do after that? And I would say most of the experts felt like if patients with nasal polyp, that they should probably undergo sinus surgery. We understand that there are some patients who may not want surgery. There are some patients who have poorly controlled asthma that won't be good candidates for general anesthesia. These are patients that maybe we should consider a biologic first. But if they've not had sinus surgery, I think most people, both in the U.S. and outside, both agreed that they should at least undergo one good sinus surgery and then followed by medical treatment afterwards. And we know that even with good sinus surgery and topical steroids afterwards, which is usually the first line of treat, the main workhorse after sinus surgery, we know that the polyps will come back in about 50% of these patients. And who are these patients? These are usually patients with co-diagnosis of asthma or ARD patients. So then if they fail the sinus surgery and the topical steroids, we can then talk about all these different options that are commonly used in our patients with nasal polyps. And, I think it's really important, when, after you the polyps come back and, they fail some of the initial systemic treatments, you want to kind of have bring in the patient and see what the patient wants. Do they really want more surgery, or do they want some type of, treatment with topical steroids or other forms of topical steroids, or, do they want to be on a biologic? And then if they do, does the frequency in which they get the biologic, is that important or not? And, and for me, what usually drives, how aggressive to be with the treatment is usually the severity of the symptoms. And so another factor in which biologic I pick is usually what are their other co-diagnoses. So if somebody has nasal polyps that are difficult to control and they have atopic dermatitis, I think dupilumab is a very easy choice. If someone has urticaria, spontaneous urticaria, and has nasal polyp, omalizumab is a really good option. If someone has EGPA and nasal polyp, I think mepolizumab is a good choice. So that co-diagnosis of what they have in conjunction with nasal polyp is actually one of the first things that I look at as well. So after you start them on a biologic, how do you know if it's working? And so the same group of the Euphoria, EPOS physicians got together and we said, what we like is, for them to have, a response. And so we defined it as a good response, poor to moderate response, and no response. And these are the different criteria that we look at. So when we do a nasal endoscopy, the nasal polyp size go down. Did we decrease the use of systemic steroids, or are there symptoms like smell getting better? And so if they had, and then the question was, how long do we decide before we say that it's not working, or when should we reevaluate them? Initially, we said 4 months. But what we realized is 6 months is a better number, because what you see in these phase 3 studies, that these patients continue to improve and improve until 6 months. So, if they don't have a good response at 6 months, you can talk to the patient about stopping treatment, maybe changing a biologic or changing therapy. And then if they do have a good response, reevaluate them another 6 months. And after that, maybe after every year after that. And there are still some unmet needs. So there are things that we know that we still need more information on. So it'd be nice to know specifically the different endotypes of all the different nasal polyp. And, the best way to do that is looking at different biomarkers. And, we still have some work to do that. We talked about the durability of the therapy, and we've seen that in some of the phase 3 data, but I wonder if we do it longer, can we do that? Because chronic sinusitis with nasal polyp is a chronic disease, we should be thinking about different terms like control. If their symptoms are well controlled and the nasal polyp score are stable after a month, we say it's controlled, but what if we can do it for 12 months? Is that remission? And can we do that? And I think those are questions that we still don't have answers to. And, and the question of maybe even curing the patient with nasal polyp. And I think before the era of biologic, I don't think that's a possibility. But now I think it is a possibility. We talked about how long do we start a patient on a biologic before we consider switching them to another biologic. And if we do the patients get a better response? And we don't know that data yet. And those are all the things that we'd like to do. And, sometimes, one of the other things that we're talking about is, can we give a biologic before we do surgery? And if we do the biologic and surgery together, will we have a better response? And so people are doing those types of studies. We don't have those data yet, but hopefully we'll be able to get that data soon. So let's return back to Jim, the patient that was presented earlier. And so, Katie, I'll turn it back to you.
Yeah, great. Thank you so much for all of that review. So getting back to Jim, given that, if you remember, he had really severe chronic rhinosinusitis with nasal polyps and had recurrence of chronic rhinosinusitis with nasal polyp after 2 endoscopic sinus surgeries fairly quickly, as well as evidence of type 2 inflammation. He chose to start treatment with omalizumab, anti-IgE. He was interested in it given his comorbid asthma, and he also wanted to have a facility-administered drug. And following 6 months of trial with omalizumab, his SNOT-22 was 41, so down a little bit from 47, but not really at the point where we think of there being a minimal clinically important difference, which is about 9 for SNOT-22. His score was still 4, so pretty bad symptoms in terms of nasal congestion or blockage, as well as his smell taste questions. And then he still had, pretty impressive nasal polyposis on his nasal endoscopy. His day-to-day asthma symptoms were somewhat improved. He was using his short-acting beta agonist less frequently. And he thought that the biologic was, helping a little bit, but still had quite a bit of impairment in his overall quality of life. So, I think in Jim's case, this is an instance where he did 6-month trial and, has some improvement in some of the symptoms, but really not what we would hope for in his case.
Yeah, and I think that's fair. And so, here, this was a patient that had multiple surgery, has comorbid asthma and nasal polyp. And I think this is a great person for a biologic. And, if this patient came to my practice, I would tell them, hey, what do you think about considering biologic instead of doing sinus surgery over and over again? And I think this 6 months is a very fair trial. I mean, and even with a 6-month trial of omalizumab, the SNOT-22 was still severe, greater than 40. The nasal congestion and smell is still pretty bad because it's a 4 out of 5. It's still severe. The nasal polyp score, is still a 5. That's pretty high. And so I would say, yes, maybe his asthma got better, but his nasal polyp is not as good as he could be. And that's not unusual. So like these patients who have comorbid asthma and nasal polyp, when we give a biologic, in some patients, they actually do better with nasal polyp, but not so much with asthma. Sometimes with asthma, not so much with nasal polyp. And so this is where I think we should have a serious conversation with the patient and say, hey, do you want to continue doing this for another 6 months? Or should we maybe consider changing the biologic, or should we do surgery? And I think I think the 6 months is a good time point in which we can present the different options to the patient and see what the patient wants.
Yeah, I would agree. I think at this point we'd expect hopefully maybe a little more improvement, but can certainly determine what the patient's goals are and figure out what they want to do for next steps. Another thing to think about for this patient is, when we think back to the biology that I introduced earlier, targeting just IgE in his case might be a little bit too narrow. So it may be worthwhile to have a discussion with him about switching biologic therapy to either one of the type 2 cytokines or something even further upstream, like one of the alarmins. So if tezepelumab, which you talked about, Joe, was approved in the future for treatment of CRS with NP, that might be something to consider in a patient like this who doesn't respond to an anti-IgE.
Yeah, Katie, I think that's a very good point, and I completely agree with that statement. Thank you. So in summary, what we talked about is chronic sinusitis with nasal polyp really impacting the quality of life of the patients, and that, if we have given them some traditional medical and surgical treatment, if they continue to have persistent symptoms, now we actually have good options. We understand that from the great lecture from Katie that chronic sinusitis with nasal polyp really is characterized as type 2 inflammation, and that a lot of the patients who tend to fail or have more severe nasal polyp tend to have comorbid or co-diagnosis with nasal polyp. I think, we're very fortunate to have a new class of drugs, these biologics that have been approved, like dupilumab, omalizumab, mepolizumab for nasal polyp. But what's even more exciting is that there are more biologics that are going to get evaluated and maybe even approved. So things that target a little bit higher, like epithelial cytokines like TSLP, And, so if we go a little bit higher, will we have a little bit better results? So it'll be interesting to see. And so with a new cytokines that we can target like TSLP, maybe we'll have, better results and not only just target asthma, but also target the nasal polyp as well. Thank you very much for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca LP. To access all materials for this activity, visit peerview.com/AYT860.